difficult and severe asthma can cause trouble sleeping and sometimes interferes with the daily activities of an individual. With the prevalence of asthma across all age groups in the state, it's an initiative of Manipal Hospital, Goa, to provide an advanced care facility that is dedicated to helping patients breathe easy and thus live a better life. As we embark on this initiative of providing advanced care to asthma patients, let us recollect our vision to be the most preferred and respected healthcare organization in every location that we operate, and strive to provide patient-centric and ethical care to our patients. With this thought in mind, let us invoke the blessings of the Almighty and the wisdom of the Divine by kindling the traditional lamp. I would like to request our hospital director, Mr. Surendra Prasad, to escort our chief guest for today, Dr. Uday Kakodkar, HOD of Pulmonary Medicine, GMC, up on the dais. I would like to request our medical superintendent, Dr. Amita Gosavi, to escort Dr. Prashant Agarwal, Medical Affairs, West India, AstraZeneca. I would like to request Mr. Hari Prasad, Head of Department, escort our senior consultants present here, Dr. Prabhu Prasad, Department of Pulmonary Medicine, Dr. Shekhar Sarkar, HOD, Surgical Oncology, and Dr. Deepak Murthy, Department of ENT, Dr. Pradeep Paidungat, Department. I would now like to request our dignitaries present on
Close your, sir. Close your.
Thank you.
Very good morning and a warm welcome to all of you. It's a beautiful moment that we are continuing our beautiful initiative today on severe asthma. So I'd like to elaborate a few details on the severe asthma and the clinic and the project we are going to program. We are going to initiate on a regular basis in our hospital setup. So this May being Asthma and Allergy Awareness Month, so asthma is a very common respiratory disease, which is complex disease and heterogeneous disease, and so in that asthma, this severe asthma is a subset of asthma, which actually, according to this year's theme of World Asthma Day, which was celebrated on 3rd of May. So they have highlighted that closing the gaps and the care of asthma. So this fits into that gap of asthma care, asthma management in the public as a whole. So to discuss on this, I would like to present it as a major unmet need of the present day. So we know that the asthma is a very common presentation in any of the public entity and hospitals. But the point is all asthma same as a whole end? So not all asthma is same. as we thought. The onset of asthma that remains uncontrolled despite the treatable factors has been removed. That means if the patient who's on asthma on higher level of treatment, like what we commonly use for treatment of asthma, that is inhaler, steroid-based inhaler treatment, if he is on higher level, but still he is experiencing the problem and difficulty in breathing, not control his asthma, then we need to think of this subset of severe asthma, because then that is the point where we should think as not as a traditional approach, as an advanced approach, that we need to differentiate what biological problems or pathways is being happening in that patients. So to elaborate on this, as I said, the severe asthma is that remains uncontrolled. That means the patient will experience persistent symptoms and frequent serious attacks, despite the treatable factors has been addressed. Treatable factors here, I mean that the patient's the acceptance of treatment, that is the inhaler therapy, the adherence to the treatment, the inhaler technique, if that has been corrected, and if the patient still put on higher dose of inhaler therapy, if he still feels not good, not controlled on asthma, then we think of this condition called severe asthma. So why we have to bother on this subset of asthma? So as an international estimate, it's been seen that 24% of whole asthma patient will have on higher level of high intensity, high inhaled dosage steroid inhaler therapy, and about 17% of these patients are found to have a difficult to treat asthma. So among this 17%, only 3 to 10% of these patients fit into this severe asthma. But the percentage is very small, but still why we are worried. The reason being this severe asthma entity causes a huge burden on the patient as a whole, as an individual, and it creates an emotional and psychological burden on the individual, on the healthcare cost will go up, and the hospitalization because of this disease severity goes up, and his quality of life will be impaired because he cannot do his regular activity, regular job, he cannot do all this thing. That is why we are worried. These kind of patients will experience frequent severe asthma attacks, and they come to the hospital or emergency and they need in the ICU experience it. So we need to see whether the patient is really having asthma by taking a proper medical history, by taking a questionnaires, by doing a physical examination assessment, and by a lung function test and other comorbidity assessment. After that, we see how much this asthma is severe. So this kind of systematic and multidimensional assessment is needed. Teaching is self-management and triggers, and identifying the managing of comorbidities, and then thinking what level of biological things is going on in his body for this asthma that is not fully controlled, and then you need to target that pathway. That is what the science has become, to personalized or stratified medicine asthma in these days. So these three domains of area which we need to consider in this case of patient, that is airway domains, comorbidity domains, and risk factor domains. Airway domains means to confirm the all this thing assessment has to be done, and then those factors has to be removed before you label it as a 3% to 10% of asthma, severe asthma patient, and then you target those condition for this thing. This approach is called phenotyping of asthma, and then you know the phenotyping actually it's a very targeted approach where we do certain type of markers, biomarkers we call. Either it could be a blood biomarkers in the form of levels of IgE, in the form of eosinophils levels. We have a lot of our patients coming with high eosinophils, but really those eosinophilic pathways causing the problem in asthma, or how much level of eosinophils are there running in his body, and what can be. So that's the phenotyping, and then once we do the phenotyping, we can address and directly target that, and then the patients can be managed accordingly. So these are the commonly noted phenotypics of asthma. From asthma now, as I said, has moved from a single diagnosis of asthma into whether he has an allergic level of asthma, whether he has a eosinophilic level of asthma, whether he has a non-eosinophilic level of asthma, or whether he is a neutrophilic asthma. All those things has to be taken care, and then we need to address with a certain targeted treatment as elaborated. I'm not going in detail because each pathway of asthma is having a different molecule injection based or medication based or procedure based approach in that asthma. So as I mentioned, one treatment does not fit all in these kind of patients. We need to personalize this. We need to go in depth, go into the biology of the patient, and then isolate the biology, and then along with your regular inhaler treatment therapy, you focus on adding the newer targeted treatment. Either it could be injectable biologics which are come these days, or it could be medication, or it could be a newer bronchoscopic procedure which I'm going to enlighten in a few, one or two slides in the coming talk. So, as I mentioned, predominantly asthma is a steroid-based treatment. You know, we put a lot of steroids on patients, and patients of this, especially particular severe asthma patient, will be having a higher dose of steroids, either tablet-wise, yearly 2 to 3 times, 4 times receiving, but not effective. But really, these kind of oral steroids are not good, and they have their own adverse effects. We need to have a stewardship, and we need to find a solution, and then target and try to reduce the steroid treatment and try to put on the non-steroid approach and reduce those. So that is where our innovative severe asthma clinic, what we are thinking. So most of the time in this particular center, where we specialized centers, we will be converging most of the referrals to this and organize, and the approach we will be targeting on different domains, that is multidimensional and multidisciplinary. Here also a lot of other departments will be involved, ENT or surgical, to tackle the issues, cardiac, everything will be tackled. Once those factors have been removed from the asthma patients, then you isolate this is a purely asthma patient, and then that purely asthma patient is having a severe asthma, and he is having a different pathway of whether allergic or eosinophilic or any other. So this is the proposed planning pathway we are thinking on this severe asthma clinic center we are going to run on weekly, twice basis. So basically we will be having a clinical questionnaires particular to this severe asthma, and then we will be confirming the asthma diagnosis, addressing the comorbidities, addressing the risk factors, and doing the phenotyping, that is doing the biomarkers and doing the blood test and allergy skin prick test to see allergy pathway. All those things is done, and then we are going to treat accordingly with the targeted therapy, either with the biological injections or with the other things. So the main focus of service area in this severe asthma clinic will be to see the non-inhaler therapy approach along with the inhalers to be continued till the patient is on controlled asthma, to initiate the biologics therapy, that is a injectable monoclonal antibody therapies which have come these days. Each patient, allergic patient or eosinophilic patient, non-allergic patient, and giving the allergen immunotherapy because certain patients of allergic will have a troublesome allergies, and if you target that immunology of that allergy, whether dust allergy or dust mite allergy or food allergy, so then his asthma or allergy things is going to be controlled. And another newly proposed stated procedure which has come into the practice is a bronchial thermoplasty, which I'm going to enlighten in the future slides. So these are the common biologic injections therapies which are approved in India, has been used for last 10 years. The first one to start was omalizumab, which is called monoclonal antibody targeting the allergic pattern of asthma, and the second one is mepolizumab, which was done, and the third, which is available and approved in biologics in India, is pantalizumab in the name of Pasendra. And these actually have revolutionized the asthma treatment in certain group of patients, in certain selected patients, in a different, and it is being given on a weekly basis or monthly basis according to two different pathways. So as I mentioned, there is another procedure which is bronchial thermoplasty. This is a non-pharmacological therapy. That means it's a non-medication or non-procedural type of therapy, which is FDA approved and also recently got IRDA approved. And the basic idea in this is, certain type of asthma patients will have a characteristic of having a very, very thick, smooth muscle in their breathing tubes, that is airways. So this procedure is basically a bronchoscopic procedure. In that there will be a certain catheter which is passed and try to heat that smooth muscle or this thing, and so to reduce the bronchoconstriction and reduce the asthma attacks and improve the quality of life. So this is the device which is available in the practice, where you have a console of heat generating system, and you have a special catheter called Allied catheter. This catheter is attached to this console, and the procedure, the catheter is passed like this in the bronchoscope. That is, bronchoscope is done, put, and then reach to peripheral airways. Through that, the catheter is placed, and the catheter will be placed in a different segments and different settings and sessions, and then the heat energy, the radio frequency energy is passed to burn the wall of the breathing tube. And this is kind of a minimally invasive decade procedure, bronchoscopic procedure, but only in a certain selected cases of group of severe asthma, not in all the patients. So who are maybe not responding to the medicines, not responding to the inhalers, not responding to biologic injections also sometimes. So we are using, and in our India, almost 7 centers they have this kind of procedure service, and we are fortunate that we are thinking to have this service in here, and we will be shortly upgrading to this service and going to give a benefit to the certain severe category patients of asthma. So to conclude, asthma has moved from traditional approach treatment to a stepwise treatment to a precision medicine, that is a stratified medicine. It is no more all asthma is a one group and you give one inhaler and he will be improved. It is that you divide which group are you belong to, which category, which pathway, which biologic pathway is happening in your body, and then you targeting that with the special injections and treatment therapy, either with available therapies and all. So to conclude, so definitely inhaler therapy is the mainstay treatment, which is steroid based, but if you add on or fill into this inhaler therapy, the add-on therapies like biologic agents, monoclonal antibodies, and the special procedures, and you are going to give a wonderful benefit to the patient and improve the quality of life and make his life beautiful. So to that, I will be concluding the talk. Thank you very much. So.
Thank you, Dr. Prabhu. I'd now like to invite Dr. Nathaniel Pinto, Consultant Pediatrics, Manipal Hospital, Goa, to share with us the pediatric perspective of severe asthma.
Good morning, everyone. Most of the things have been covered by sir, but I'll give what is very specific to the pediatric approach in asthma. So, as sir said, there are two types, severe, which is treatment-resistant asthma, we call it SPRA, and second is difficult to treat asthma. So it is very important to differentiate between the two before we start the treatment. Now most of the asthmatics which are difficult to treat asthma are often with comorbidities or often underlying conditions which are not addressed, and these patients are mistakenly said to be severe or treatment resistant asthma. So when these patients come to a specialist, these comorbidities are often picked up and treated, and this kind of asthma can easily be treated after that. However, the asthma that remains untreated even after addressing the underlying comorbidities, we call it the severe. So basically there are two different endotypes. I will not go into the details. This is mainly targeting the treatment which we use, biological treatment. So there is T2 high asthma and T2 low asthma. So the biologics which we use, like omalizumab, will work more in T2 high asthma, inflammation. So as Sir said, the treatment is becoming more and more targeted and not broad-based. We were using steroids as a broad-based treatment, which has a lot of side effects also. These omalizumab and other biologics give a targeted treatment. So if you find what kind of inflammation, so these are the common triggers, especially in children, that can trigger an attack of asthma. So what are the comorbidities? There is a term called something called asthma plus, which reflects the accurate underlying diagnosis with an other underlying factor that worsens the underlying state of asthma. So what are these comorbidities in children? There is a big list of comorbidities. Most common which we need to see is allergic rhinitis and chronic rhinosinusitis. These two very common factors often tend to worsen the underlying asthma and need to be addressed as soon as possible. One more thing which is very common is something called gastroesophageal reflux, which can also worsen the underlying asthma and needs to be addressed. One topic which is not very well addressed in children is that it causes high psychiatric morbidity. Hence, at initiation of treatment, psychosocial assessment of the child as well as the caregiver is important. Children with severe asthma tend to have a high level of anxiety, difficulty in coping with their disease, because they often have to take the inhaler, and taking it in a public place might mean you are not well. Okay, so among children, these creates a lot of issues and needs to be addressed. Caregiver psychosocial stress is also associated with high asthma morbidity. So depressive symptoms in the caregiver are also important, and there are some sort of I would say biases. Parents ask you, if you want to start the child on inhaler, will my child remain inhaler for long? So there is a lot of resistance before starting the treatment because of the bias and what other people will see. So these issues need to be addressed before the child is started on any type of treatment. Now, in difficult to treat asthma, sometimes there may be some asthma mimics, some diseases that mimic as asthma. So when you will suspect this, especially in a younger child, children less than 12 months of age, in an infant who's wheezing continuously, if there is isolated chronic cough, in absence of wheeze, there is no wheezing but only chronic cough. Children with sudden onset of symptoms, they have no previous history, okay, and absence of nocturnal cough. Now nocturnal cough is very specific in asthma. It usually starts at night between 1 to 4 am. So if the disease is an asthma mimic, it will, absence of the nocturnal cough will be absent. And finally, there will be no response to a standard asthma treatment. These are again common conditions. These are the asthma mimics that are there. Okay, so there's a big list which I would. In this. When do we have to consider alternate diagnosis of asthma? If we start all the treatment of asthma, the child is not responding to this, then when should we consider alternative diagnosis? When there is associated developmental failure, when the child is having a poor weight gain, when the child is having a wet productive cough, there is a sound called stridor, rapidly declining lung function, and if the child does not have associated allergies, then you will consider an alternative diagnosis. Only two issues that I want to cover in terms of pediatric. This is adherence. You have to check adherence of the patient at every visit. So how will you do that? Ideally, they say you can check the canister weight and doser measurements to see whether the doses have been taken or not. Because if the adherence is suboptimal, then the asthma is never going to improve. So adherence has to be assessed. Second point, reviewing the medication delivery steps is very important. You have to demonstrate to the patient, ask the patient to repeat these steps during every clinical visit. So this reinforces in their mind how the dose is to be given to the child, how the steps are. This has to be reinforced at every visit. And finally, home environment assessment. In children, the allergen exposure may be repetitive at home. It might be dust, it might be the dust mite, it must be some smoke, there might be pets in the house, the animal dander is causing the repeated asthma attacks. So environmental assessment at home is very important, and taking the corrective steps so that the child doesn't get repeated exacerbations due to these allergens is important. Finally, when to report to the emergency room, the parents have to be told. A written plan has to be given to be followed on 6 days. Parents should not remain with the child home until it is a later stage. Patient should present to the ER as fast as possible. And finally, explaining something called peak expiratory flow measurements to the parents, how to calculate it. I will not cover this. This is all has been covered. Only couple of words on biologics. There are 2 biologics which are in use for children, omalizumab, and the second one is mepolizumab. So the indications for use of these 2 medications would be that what I have mentioned here. If the Ig levels are very high, if there is evidence of allergen sensitization, the child has had multiple asthma attacks and is not responding to other therapy, and children having asthma attack despite step 5 therapy, which is systemic steroids and high dose inhaled steroids. In them you would consider biologic use. There are certain biologics which are still in study phases and in later stages might be approved for child use. Bronchial thermoplasty currently is not approved for patients less than 18 years of age. So that's about it. Thank you.
Thank you, Dr. Nathan. I would now like to call upon Dr. Prashant Agarwal, Medical Affairs, West India, AstraZeneca, to say a few words.
Good morning, everyone, and thank you so much for this opportunity, Dr. Prasad and the whole Manipal team, Mr. Hari. So, first of all, I would like to congratulate Manipal Hospital for this great initiative, because in India, if we think the care of this uncontrolled asthma has been lacking, okay, and we haven't been able to provide this care in a precise manner. So, hearty congratulations to Manipal Hospital for beginning this, and I'm sure this is going to bring a revolution in the care of severe asthma. Why? Because though the severe asthma is, having 5 to 10% of whole asthmatic population, the resources used by the severe asthmatic patients, for example, hospitalization or emergency department visit, they are almost 50% of all the asthmatic resources used. So you can think, even this 5 to 10% patients, they are using 50% of the resources provided by the hospitals or provided by the government. So that's why it's become very important to take care of this patient in a very precise manner. These patients which are uncontrolled asthmatic not only have the symptoms, but they have so many other things going on with them simultaneously. For example, comorbidities, like Dr. Prasad has told. And not only they are suffering, their family members are suffering. I know, I have been hearing, being in medical affairs, some patients and their relatives, caregivers, that how they are suffering with their patients. 20 years, 30 years, these patients haven't been able to control their symptoms. Night awakening, they are not able to sleep properly. They are totally limited their activity. It means they are not able to go. They are afraid to go out because they know that any allergy or any dust, any pollution, polluting material can cause asthmatic attack. So, for that, holistic care in the form of severe asthma clinic is very important. like Dr. Prasad has shown what is the holistic treatment and what are the management facilities which will be available. So from the AstraZeneca, I would like to talk on the Biologic, because AstraZeneca, being a patient-centric company, spends billions and billions on research and development and comes with an innovative therapy for the management of some treatment which is not managed currently with the standard of care. For example, bendalizumab, this is the biologic or monoclonal antibody that has been approved in India for severe eosinophilic phenotype of severe asthma. It has been seen that these patients of severe asthma, which are suffering, 60 to 70% of these patients are having higher eosinophil, and eosinophil is the more important factor that causes these symptoms which are uncontrolled. And to control this eosinophil, that if eosinophil can be depleted, it will really cause the symptoms improvement and the improved lung function of the patient. So that's why AstraZeneca Research and Development, they have worked and have brought bendalizumab, which is a anti-eosinophilic monoclonal antibodies. It has been approved till 2017 by FDA and last year by DCGI India, and we have been fortunate that we have been hearing that more than 1 lakh patients globally have taken bendalizumab. Their testimony, and in India almost I think more than 100 patients, and I have been hearing the quality change or the symptom change that happened after taking some doses, a few doses of bendalizumab. And I'm sure this clinic would be able to identify such patients who are really eligible for such kind of therapy and would support. So I wish you all the best for your clinic, and I promise that AstraZeneca would be able to support in scientific manner whatever we can. Thank you so much.
Thank you, sir. I would now like to request the hospital director, Mrs. Surendra Prasad, to kindly escort our chief guest for today, Dr. Udai Kapurkar, and the other dignitaries present in the first row for the formal launch of our severe asthma clinic.
प्रसाद डोकं येते कुठच्या इंटरनॅशनल मीडियाला फोटो देतो एवढं मध्ये धावतो ते
His asthma remains uncontrolled, that is, he experiences frequent severe asthma attacks with no improvement in symptoms. Jay recently visited a chest physician to discuss his health concern. The doctor explained him about severe asthma. It is a type of asthma that remains uncontrolled even after taking maximum recommended treatment regularly. Addressing treatable factors like taking inhaler properly and ruling out other diseases. Jay's doctor also tells him about the newest development in treatment of severe asthma. That is biologics. Biologics are targeted therapies designed for different types of severe asthma. They are made from living cells. These can be taken as injections or infusions. These are add-on therapies that can be taken along with your current asthma treatment.